This is Dolores Javens, and today I am going to present conduct disorder case study of Kyle number 6. And I will begin the presentation with the first slide. Introduction to Kyle. He is a 12-year-old male who reluctantly agreed to be admitted to a psychiatric unit for the first time. His precipitating event is a recent arrest due to breaking into a grocery store. Medical history, his early development was uneventful, no medical problems, and all of his milestones were met on time. Mother reports no problems during her pregnancy. He has a negative history of physical or sexual abuse, but mental abuse was not addressed in this case. There's no history of alcohol or substance abuse reported. Social history includes the fact that he lives with his mother, his stepfather, and 2 younger half-siblings. His biological father is in prison due to drugs. Both grandfathers have a history of alcohol abuse, and mother works as a cashier part-time, and the stepfather is unemployed. His mental status exam upon admission shows that he was very fidgety and made sporadic eye contact. He was dressed casually and appeared his stated age. His mood was angry and irritable. Affect was angry. He denies depression, suicidal ideation, or homicidal ideation. Limited insight and poor judgment. He does state that he'd rather be in jail than be in the psych hospital. Speech was loud but coherent and of normal rate. His past behavioral history includes a lot of aggressive bullying as a young child that was unusual, as well as stealing. When confronted by authority figures like the mother, stepfather, or teacher, he would curse, punch, and show no concern for any possible punishment. In 2nd grade, he was diagnosed with ADHD and was in special ed classes. In the 4th grade, he saw a psychiatrist and was prescribed dextromethorphan and quetiapine, and he just sporadically took those medications. He would call his psychiatrist stupid as well. Recent behaviors in the past year, he's been in a lot of physical fights, stealing from the school lockers, was arrested twice and multiple suspensions, and he mugged a classmate for his wallet. Collateral information obtained was that he is not liked by his peers. The mother and the teachers say he's a loner. He's unremorseful. He will externalize blame, uninterested in others' feelings. Very disorganized, inattentive, not interested in instructions, and constantly loses his possessions. Protective factors include the fact that he has no gang activity, no pyromania, no cruelty to animals, no weapons, no running away from home or school, no SI or HI, no known history of suicide ideation or attempts. His diagnosis is conduct disorder, childhood onset type, severe with limited prosocial emotions, according to the following DSM-5 criteria, which includes repetitive and persistent pattern of behavior where the basic rights of others are major age-appropriate societal norms, rules are violated, as manifested by 3 of the following 15 criteria in the past 12 months. From any category listed with at least 1 criteria present in the past 6 months. So the major criteria are aggression to people and animals, destruction of property, deceitfulness or theft, and serious violation or rules. He has at least 7 out of the 15 criteria met in the 4 major categories previously listed. He has childhood onset type because before age 10 he was aggressive, bullying, and stealing. Research shows that a comprehensive treatment plan that includes the combination of pharmacotherapy and parent training is most efficacious. Risperidone has been shown to have the best results for children and adolescents with disruptive behaviors when added to psychostimulants and parent training. Bartran et al. 2017 outlines recommendations for practice to include waiting at least 1 month after initiating parent training and psychostimulant medication before introducing an antipsychotic drug, and this is to decrease unnecessary treatment with multiple medications. In my opinion, this would be best for Kyle since his past medication compliance was poor. Additional research shows that there is support for the efficacy of adding risperidone with family therapy for long-term management of conduct disorders. And these are my references, and I thank you for listening to my presentation.